I'm happy to get started on my presentation on the role of the oral microbiome and intestinal health, what we're learning and what we can do about it. So my intention is to give you a little bit of a background in science and biology, and then make it practical and approachable in your daily lives. So it's going to be less, not just a pure sort of science talk, but can you do anything about it tomorrow when you get home? So in the preparation for this talk, it's kind of a new area for me. We hear about the gut microbiome, and you heard about the talk yesterday. Fantastic introduction to the concept of the microbiome, but I wanted to dig deeper into the oral microbiome, which is an area I didn't really know much about, honestly, about 3 months ago. And as I explored it, I just kept getting more fascinated by it and surprised by all the intricacies and value it has. So I'm going to go through a bit of a background. What is the oral microbiome? Talk about what does it do, what are things affect it, what are the environmental factors that impact the oral microbiome, and what are the connections to the gut, as we will call it, the oral gut axis. What does it mean for IBD in particular, right? And then all the takeaways we can take from all this. So here we go. All right, so what is the oral microbiome? Now, I'm willing to bet that all of you have or know a lot about the oral microbiome. In fact, every 3-year-old knows about the oral microbiome when they see this picture. All right? So everything we've known about all along about sugar and cavities is the oral microbiome, right? Because you don't just get sugar from cavities, you get it through microbial metabolism of the sugar in your mouth, producing waste, which is lactic acid, which then chews away at your teeth and allows a cavity to happen, right? I mean, we've known this for decades, right? So you're already a pro. Every 3-year-old is already a pro. They try and brush their teeth or kind of cut back on the sugar intake. This is a picture of my kid's dental office. Just like any old dental shop, they have flyers. And then right there on the counter is a bunch of candy. All right? So have we even learned anything about this? No. So again, one of those things where you have to be the person in charge. So let's explore this a little bit more. So the human body, and you know this, particularly the digestive tract, is home to a complex community of bacteria known as the microbiome. And these bacteria play a crucial role in our health and well-being. The composition of this microbiome can vary significantly between different parts of the body, right? So, for example, the bacteria found in the mouth are actually very different than those found in the stool. Now, this is because the bacteria in our bodies are not just simply passengers. They interact with our bodies in ways that can affect our health. For example, they help us digest food, produce vitamins, you heard about this earlier, and protect us against harmful bacteria. So there's a reason they're coming in us. They serve a function, and the different parts of our body serve as different niche or ecologies for each of these microbial communities. Now, changes in the composition of the microbiome can be associated with various health conditions, including obesity, diabetes, and inflammatory bowel disease. The microbiome is not static. It's another key learning lesson. It changes over time. It can change in response to factors such as diet, medication, think of antibiotics, lifestyle, and various disease states. And the composition of this microbiome in the mouth is unique to the composition that you might find in the stool. I mentioned that earlier. This suggests that different parts of the body and different parts of the digestive tract provide a distinct bacterial ecology that nurtures different kinds of communities in different locations. The bacterial composition in the stool is more diverse, right? That's the gut microbiome arriving in the stool, being sampled in your measurements and kits that you might send for microbial analysis. That stool is quite a bit more diverse than the microbial community found in the mouth or in the throat. Again, this is due to different functions and environments of the digestive tract. So inside the lower gut, there's incentives to have a much broader, diverse community. In the oral cavity, it's a little bit different. So for example, Streptococcus is more common in the mouth, but Bacteroides is more common in the stool. So you get this sort of differentiation of strains and species co-locating or specifically locating in one or the other parts of our body. Now, the oral microbiome is a collection of more than 600 microbial species living in specific ecologic niches inside the mouth. Approximately 170 of these species are considered to be core to the mouth. So that's sort of like your baseline ecologic state, 170 species, and then it can go up and down depending on the state of affairs and the person, what they're doing, and I'll talk about that in more detail. And then we're just beginning to understand the composition of this oral microbiome and its relationship to intestinal health. So this is a pretty new area, but we are able to make some extractions and decisions and conclusions as it relates to our health. And then understanding all this possibly gives us some new strategies to approach our health in a much more coordinated way. Now, this is a fluorescent scan of the human tongue, all right? So the shape is actually the full tongue. And these researchers were able to produce these fluorescent dyes that adhere to different microbes in the mouth. So you kind of wash the mouth with this fluorescent dye, and you allow the dye to stick to the microbe it's designed to stick to. And here's a 3D sort of visualization of it. What this shows is that not only do you have different microbes in the mouth, but they kind of find their own niche within the mouth itself. So the Neisseria, the yellow, kind of group and cluster together in a little community, kind of in patches, as you would expect a microbial community to grow in little patches. And then different species or strains kind of group themselves into different locations. So it starts getting really interesting, well, what's going on? Now, there's been a lot of emphasis on the gut microbiome. There's a lot of journals. This is in gastroenterology a few years ago. Lots of articles on the gut microbiome. I pulled up all the articles that had the word gut or stool microbiome published in PubMed in comparison to the oral microbiome. Okay, and so you can see the difference. Like we're really far along in the gut or fecal microbiome research publication space, but look how far behind we are in the oral. So there's still a lot to learn, but again, there's already quite a lot in place. So I extracted a lot of interesting information and put it together for you. So for example, the oral microbiota is acquired early in life in an ordered sequence. The common oral species are shared between children and their mothers. So there is a kind of an overlap between mother and child oral microbiome. However, there's no evidence that mother and child strains share from each other. So vaginal birth does not make a difference, or breastfeeding does not make a difference, at least enough to be able to be detected. So what's going on? Where else is the child getting the microbiome for the oral? So this suggests that contacts the child has, the shared environment anybody has, individual behavior in our lives actually determine the composition and the transmission of oral microbes, not genetics. So earlier today, Natalie talked about kids picking up food from the ground, from age 1, they're just grabbing and picking up anything they can put in their mouth. That's the exposure I'm talking about from early in life on through. And that's a driving factor in what ends up in your oral microbiome, definitely not genetics, and less so from a maternal-child transmission. Studying the extended families showed that fathers and mothers were actually equally similar to their children. So again, there isn't this sort of maternal birth-child interaction. It's more of the household environment and exposure, living in the same habitat, that drives the similarities. In fact, cohabiting couples show an even greater strain similarity than mother-child pairs. So let's say a husband and wife actually have a much closer shared community in their oral microbiome than a mother-child. And I'll show you some examples of that later. Unique combinations of these contacts and the shared environments that people share ultimately shapes this highly personalized human oral microbiome. So the diversity of our salivary, we'll call it the salivary microbiome, can be influenced by factors such as smoking and personal oral hygiene. Our oral microbiome diversity is associated with systemic health factors, and I'll spend a lot of time on this. Good oral health is associated with a lower diversity of salivary microbiome. So good oral health reduces the diversity in the saliva, and that's actually a good thing. So in contrast with the gut microbiome, where you want to expand the diversity and increase the range of species in our guts, in the oral cavity, it's the opposite. Increased diversity is a bad thing. But there's going too low is also bad. So having a low diversity is also associated with bad outcomes, including high tooth loss. So there's a middle zone of not too high, not too low in terms of diversity that drives good health. For example, prolonged plaque accumulation in the mouth results in the multiplication of these bacteria that are attached to the tooth surface, and that's not a good thing. It causes compositional shift of the microbes to this highly diverse community due to this altered ecologic condition in this biofilm that's formed on the tooth. So plaque formation drives expansion of the diversity in the oral mouth, and then all of a sudden bad things start happening. Cavities, I mentioned them earlier, are produced when they produce a roughened tooth surface, right? And then that roughened surface allows bacteria to attach to it when normally it wouldn't even have a chance. So that's another driver of when one thing goes bad, it induces increased diversity of the microbes into those surface areas. They also produce this acidic environment that further changes the local ecology, this sort of acidic pocket area, and that changes the kind of microbes that can or cannot live there. And again, we get this downward spiral of plaque formation. Smoking has an impact not only on tooth-associated communities, but also on the mucosal microbiota in the oral cavity. So smoking is this environmental exposure of whatever, toxins, smoke particles that goes through the cavity as somebody smokes the smoke, right? You breathe it in. It has to travel through the oral surface area. That exposure is enough to impact the oral microbiota and cause a disruption in the ecology that can survive there, right? Now, a little side note, smoking has oddly been associated with a protective effect on ulcerative colitis. Not in Crohn's, but people who smoke tend to have a bit of a protection from the smoking cigarettes in UC. Nobody's been able to explain that. Okay? So, is it doing something in the mouth? Like the oral ecology is changing from the smoke? I'll talk about that. All right, what are the health implications? The correlations between oral dysbiosis, we'll call it this sort of shift in the oral microbiome, oral dysbiosis, and the overall systemic disease is varied and pretty broad-reaching. So let me give you some examples. In cardiovascular diseases, there's a linkage between oral dysbiosis and the mouth going through sort of periodontitis, the sort of bad, healthy gums and infected gums is a risk factor for cardiovascular disease. In fact, oral microbes, oral bacteria, have been found in the plaques of atherosclerosis. So when you go inside the arteries and you find a plaque, right, they actually find the microbes that used to reside in the mouth. How did it get there? Did it cause the plaque? We don't know. The higher the oral bacterial burden, in the mouth is associated with higher risk of atherosclerotic plaques. So there's a definite known connection there. In terms of diabetes, the oral microbiota of diabetic patients is significantly different than non-diabetic patients. The abundance of certain oral microbes is actually correlated with blood glucose levels. So something in the mouth, the microbes, they're doing something, and it's being seen in the blood glucose levels. Again, we don't know if it's cause or effect, but there's a correlation there. With Alzheimer's, there's been linkages to oral dysbiosis. This organism that's normally found in the mouth has actually been found in the brains of Alzheimer's patients. So an oral resident microbe is found in the brains of Alzheimer's patients. How did it get there? Okay, we're going to explore that. Rheumatoid arthritis. Again, oral microbiota of rheumatoid arthritis patients significantly different than healthy individuals, and the abundance of certain bacterial species is actually correlated again with disease activity. So some shifts in the oral microbes going out of whack increases rheumatoid arthritis disease activity, or you can call it a flare. In cancer, oral microbes of pancreatic cancer patients are, again, significantly different than healthy individuals, and certain bacterial strains are abundant in cancer patients, again, suggesting a connection. So there's this big, broad range of systemic diseases that are pretty closely tied to what's going on in the mouth. So let's see what's going on closely. So on the left, you see a healthy tooth and a gum composition. Again, think about the barrier function of the intestine. There's also a barrier function in the mouth, right? There's contents of inside the mouth, barrier, and then the inside of your body. On the right side, you see what a diseased tooth or diseased gum looks like, and you see disruption of that barrier, right? We've heard about this. There's inflammation right at the gum surface area, and then the beginnings of tooth loss. This then starts triggering a whole sequence of things that then get impacted across all sorts of health conditions. I just went through a few of them. IBD is listed up there, and I'll dig into it in just a second. So that's kind of a little background on what the oral microbe is and what we know at a high level. Let's see what's going on in terms of how it's driving health or disease. So it's important to know that what happens in the mouth has both a local effect. So all these shifts in the oral microbiome has a direct local influence at the mouth level, and I'll give you a lot of examples there. And then there's a secondary effect through the intestine where microbes actually end up in the intestine and then cause trouble down there. So from now on, I'm going to explain two things: what's happening in the local mouth area, and then what's happening systemically via the gut axis. So let's talk about the first one. What kind of things happen in the mouth that could be beneficial or detrimental? So let me give you a story of nitric oxide. This is going to be a little bit of a side tangent, but it gives you a really good example of what I'm describing. And nitric oxide is the best known example in this area. So what do we know about nitric oxide? Nitric oxide is a gas that is produced in the body that regulates blood pressure. So it's produced in the veins, in the blood vessels, to manage blood pressure. Now, 1 out of every 3 Americans is already dealing with hypertension, high blood pressure. It's the leading cause of death in the US and worldwide. And despite aggressive treatment with medications, blood pressure, only about half those medicated really benefit from the treatments. So their blood pressure management is really off kilter, even with medication. Now, nitric oxide is a signaling molecule made by the body. As a gas, it easily moves around and quickly penetrates all the nearby cells, and it acts like a little messenger. It's a signaling molecule. And it tells the arteries, the walls of the arteries to relax. So imagine a hose that's capable of expanding in diameter or shrinking in diameter. That's your blood vessels. Every time nitric oxide shows up, it tells the arteries to relax and broaden out, like expand the diameter, and that lowers the pressure of the blood in that area through that artery. It's a wider channel. When the nitric oxide is gone, there are other forces that can constrict that blood vessel and narrow it down, and now the blood pressure goes up. So people with high blood pressure have this high level of narrowing that restricts the blood flow and increases the blood pressure. When nitric oxide shows up, it opens up the artery and relaxes the surface area, the walls, and then blood pressure goes down. So your body has this intricate method of opening and closing the blood vessels, and when it does that, it allows the 4 or 5 liters of blood that you have to be distributed to different parts of your body. It's sort of like its own internal plumbing system that sends blood to where it wants and redirects it from areas it doesn't need at that moment. So after a meal, we just had lunch, the gut is really working hard to digest the foods and absorb the foods. We need a lot of blood to sort of go pick up all those nutrients. So right now, whether you know it or not, your blood vessels have relaxed in the intestine, opened up, and more blood is arriving there right now to go pick up those nutrients and distribute them elsewhere. When you go on a treadmill, all of a sudden your body is like, okay, I need more blood in my legs, and they need the oxygen and to pick up the waste. So all of a sudden the blood shifts in its sort of distribution and sends it to your legs where it's needed. So this is an intricate and delicate signaling action, and nitric oxide is intimately involved in all of this. And so your body makes it on demand when it needs it. Now, the whole biology of this was discovered a while ago, but in 1998, there was actually a Nobel Prize in medicine given to this. Dr. Luis Ignaro is the inventor or the discoverer who characterized this, and so it's a pretty big deal. It obviously is a big part of cardiology and cardiovascular disease, but hasn't really picked up more broadly that we know. Like, it's sort of like a little ignored area of science. Now, there are 2 ways of how your body makes nitric oxide. One is by your endothelial cells. These are your blood vessels. I just described that. When they need to open up, they get the message, they produce the nitric oxide from an amino acid called L-arginine. Right? L-arginine is an amino acid. They can convert it to nitric oxide on demand and immediately loosen up the blood vessels. Like, they relax, perfect, works in an instant. The other place that nitric oxide is made is in the mouth, okay? And the way that works is it doesn't start with an amino acid. It starts with nitrite, dietary nitrate, I should say, that we eat in our foods. Right? So fruits and vegetables, I'll explain that in a second. We consume fruits and vegetables that contain nitrate naturally, and then our oral microbes see the nitrate and convert it to nitrite. Right? And that conversion can only happen by these oral microbes. We can't really do that as humans. And then that nitrite feeds the pathway to generate nitric oxide. So there's 2 separate pathways. They sort of parallel each other and back each other up. As we age, the pathway on the left, the endothelial pathway, starts diminishing in its capacity. So with every decade of life, the left pathway becomes less efficient, and our ability to make nitric oxide becomes poorer and poorer, just part of aging. So we kind of tend to rely more on our oral microbes to do the job. Now, the nitrite I'm talking about comes from green leafy vegetables and root vegetables. So things that are actually right smack in the middle of SCD compatibility. Again, we lack this enzyme to convert the dietary nitrate into compatible for production of nitric oxide, so we rely on the microbes in our mouth to do the hard work for us. And then once they do the job, we can take it from there. So nitrate is broken down into nitrite, and then secondarily into nitric oxide. So it's kind of a 2-step process. Nitrate is in the diet. The microbes convert it to nitrite right in the mouth in an instant. and then our body can take that nitrite and produce nitric oxide. Okay, so it's primarily found in green leafy vegetables, like I mentioned, and root vegetables. It's a repeat. Okay, so here are some microbes that live in the mouth that can actually do this work. So these are all being characterized, a whole range of microbes that are really good at this stuff. Give them the nitrate, they're happy to convert it to nitrite, and we appreciate their help, right? We rely on it, actually. So somebody asked about chewing. So chewing, we've all been told that chew well, slowly, don't rush your meals. Slow chewing allows the nitrites, the nutrients, to reach the crypts of the tongue, the little cavities all over the tongue, for the bacteria to even have a chance to break it down. And then this nitrate is converted to what I just described. So chewing is very, very important. Chewing is very, very important, and it allows the food not only to break down, but for the microbes, for that instant, for that 20 seconds, 15 seconds, 10 seconds, to have a chance to break down and do this little conversion for us, right? And then you swallow, and then it's over, right? So that 10 seconds, 20 seconds, if you chew for 30 seconds, great, right? And a lot of chance for the action to go to completion. It's never going to be complete. You will definitely swallow some nitrates without converting them to nitrite, and they'll end up in your stomach. But it's not a lost cause, because I'll tell you in a second what happens. So any unprocessed nitrate that you accidentally swallow, because maybe you just chewed too fast or you didn't have enough time, it ends up in the gut, and your mouth actually puts it back into the saliva, recirculates it, and sends it back upstairs. And it gives it a second chance. So when you salivate, there's nitrate that got back up into the saliva for a second go around, right? So first chance, didn't make it, ends up back in your saliva, and your body sends the saliva back to the mouth next time you eat, and the saliva contains the nitrates for further metabolism into this good nitrite that your body is looking for. So salivation is important as well, not just chewing. All right, not only does it have digestive enzymes in it, but it has other things that your microbes are waiting to see and then get going. So this is really kind of feeding this notion of mindful eating, slow eating, being careful with your chewing, and definitely having vegetables and root vegetables and greeny leafy components in your diet. All right, so yeah, this whole circular action, this kind of ending up in the stomach, coming back into the saliva, happens over hours of time. So this is all going on in the background without us even knowing. All right, so as we swallow all this, again, this is a long story, kind of a little bit of a side story, but it exemplifies how the oral microbiome, sitting in the local oral cavity, has systemic effects, right? Just from the diet and the salivation and the foods, we're producing nitric oxide and making it available for the rest of the body. And not only does it impact hypertension, but nitric oxide is also an anti-inflammatory. It's also anti-infective. It's been known to zap viruses and pathogens. So it's part of our immune system. And so it's not just a story about hypertension. Nitric oxide is probably, you should start thinking about it as part of our immune system. So again, it's involved in the pathogenesis of infectious diseases, tumors, autoimmune, and degenerative conditions. Kills off invading pathogens from bacteria, and it modulates the suppressive action of your immune system. In fact, whenever we breathe through our nose, there's a little bit of a gas expulsion of nitric oxide right in our nostrils. And people think that is a protective foam or gas or layer from incoming microbes or viruses. So nasal breathing is probably better than mouth breathing in terms of getting that nitric oxide spurt, that little gas production. All right. So knowing all this, then how do we preserve the good microbial ecology? Because it sounds like it's pretty important to have all these microbes in our mouth. They're doing a lot of good work for us. How do we maintain good oral ecology? So eating vegetables, especially beetroot, has been shown to contain a lot of nitrates, and all of these have been shown in clinical studies when you eat these vegetables to lower blood pressure, to improve exercise performance in athletics, because now you're delivering more oxygen to the muscles, I just described that, improves blood vessels, reduces the risk of Alzheimer's, and combats a whole range of other aspects of aging. We know these from clinical studies. And all these effects are lost if the subjects do not swallow their own saliva. Some people don't swallow as much saliva as others. Or if the nitrate is removed from the vegetables. So there you go. You have to have all of these pieces together, the salivation, the microbes, the nitrates in the vegetables, to then combine and work together to give you all these health benefits, lower blood pressure, exercise performance, on and on and on. Now, one quick note. Nitrates that I'm describing are not the nitrates that you see in processed meats. So we've heard about in SCD especially, don't buy nitrate processed foods, right? Those kind of nitrates are added to foods to prevent bacterial growth during shipping or shelf life. That's not the kind of nitrates I'm talking about, right? They're added to meats to make them look red and pink and consumer friendly. That's not the nitrate we want in our diet. That's an artificial food processing step. We're talking about nitrates found naturally in vegetables and leafy greens. That's what you want to be looking for as part of this sort of oral health and systemic health. Now, when nitrates production is not, or nitric oxide production is not happening in your blood, in your body, I mentioned hypertension. There are other cases where you're like really, really in trouble and your blood vessels are so constricted that you get pain in the heart, angina. This is basically the precursor to a heart attack. And guess what? The prescription medication you give is under-the-tongue nitroglycerin. You've probably heard about this, right? This is an emergency room medication for people having a heart attack. You just give them a nitroglycerin. It's the same thing. It quickly gets under the tongue, produces nitric oxide, and basically rescues the person. All right, so you don't want to find yourself in this spot. All right, so finding rich foods, again, so just some examples of how much nitrate you find in these foods. Fresh spinach, you can see a bit of a wide range, bok choy, lettuce, carrots. Depends on where the fruit or vegetable was grown, what kind of soil, what soil nutrients, and so on. So each of these is per 100 grams. And you can see a pretty broad range, but these are pretty high nutrient sources of nitrates. The body makes about 60 milligrams itself, approximately. Right? I mentioned that pathway inside the body. So if you make 60 milligrams yourself, you can actually double or triple or more than triple from the diet. So it actually becomes a pretty big source, big important source. And, we definitely want to include these fruits and these vegetables and root vegetables especially. Okay, so now that you know the sort of the sequence, all the characters involved, nitrates, microbes, saliva, all that kind of come on stage and work together and give you the performance you're looking for. How do you destroy that? How do you interrupt that? This guy right here. Okay, so mouthwash. Almost 2/3 of the American population, 200 million, use mouthwash regularly. All right, what's a mouthwash? It's designed to kill the microbes in your mouth, right? You'll see it right on the label, 99.9% effective against bacteria. It kills everything. Oh my gosh, what am I doing? Is this the best thing? So in the last 10 years, there's been some versions of mouthwashes that are non-alcohol based, because it's the alcohol that's acting as the antiseptic. So if you use alcohol-based mouthwash, you're not supporting the microbes that live in your mouth. You're actually harming them. You're killing them. That's how mouthwash works. In fact, when you give an athlete or anybody mouthwash for 7 days, their blood pressure goes up. Okay, you can see that the black dotted line, the black line above, that's the blood pressure over 7 days when you start using mouthwash. Because you're killing the microbes pretty quickly, pretty much right there on the spot, and now the nitrate-nitrite conversion isn't happening, and you get a reduction in nitric oxide availability in your arteries, blood pressure goes up. It's pretty impactful. You can see this in athletes as well. They use this antimicrobial mouthwash, and after exercise, you do get this normal reduction in blood pressure. That's the white bar. But the ones who use the mouthwash never got the reduction in blood pressure. Not good. Okay, so keep that in mind. We'll come back to that. So again, antibiotics is another way you can damage your oral microbiome. And poor oral hygiene, it doesn't support this good ecology. The right bacteria don't get a chance to live there, and they're basically getting out-competed by these new microbes that show up because the oral hygiene isn't what it needs to be. All right, so that was a little bit of a side story of nitric oxide, but it gives you a really good example of what's going on in the mouth, the microbes, a very well-defined pathway of affecting not just blood pressure systemically, but other things involved in nitric oxide metabolism, acting as an immunosuppressant, acting as an anti-infective agent. So now let's talk about number 2. What happens when the microbes in the mouth get distributed elsewhere? This is now not a local effect, but an effect through the gut. All right, so the average person generates about and ingests about 1.5 liters of saliva every day. Okay, so that's quite a lot of saliva that's produced in the mouth, swallowed by everybody. It's normal. It happens a lot. And with every time you swallow the saliva, guess what? You're also swallowing the microbes. Okay? Nowhere else to go. And this increases the level of microbes of oral origin been found in the gut. So in clinical research, we've actually found oral microbes in the gut of IBD patients, HIV patients, people with liver cirrhosis, colon cancer. They just keep finding these oral microbes that have persisted in the gut of these conditions, and I'll get into that a lot more. So as examples, these oral microbes that I listed in red here have been isolated in the intestinal mucosal microbiota, right? And it's also been associated strongly with disease status of Crohn's disease. So those 2 microbes in red you see here, when they show up in the gut, you see that in active Crohn's disease, okay? Not elsewhere. So we actually have a lot of data on this. These species you see in red here are significantly more abundant in the fecal microbiota of patients with ulcerative colitis, PSC, acid reflux, and people, alcoholics. So what's going on? Why are these microbes ending up in the stool of these patients? These microbes are not supposed to be there. They like oxygen. They're aerotolerant. They're in the mouth, exposed to air, exposed to oxygen. What are they doing in the gut? We'll explore all of that. Now, interestingly, the people who had acid reflux were also being treated with proton pump inhibitors, antacids, right? And so that inhibition of acid production in the stomach allows the microbes to get a free pass right through the stomach into the small intestine. The stomach produces acid for a couple of reasons. 1 is to digest the food, and 2 is to sterilize the food. Microbes can't survive that acid bath. When you're taking antacids or protein pump inhibitors, which is very common, that acid production goes down, and the microbes basically get a free backdoor entry into the small intestine. Nobody there to stop them. So this is a very overused medication for acid reflux, meant to be a short-term thing. A lot of people are on it chronically, and the microbes basically get a free entry into the small intestine, intact, alive, maybe causing trouble. Now, I mentioned those 4 conditions, ulcerative colitis and so on. I also mentioned that when the oral microbiome is not in a good place, the diversity goes up. Remember that? We want to manage the diversity, and when the oral microbiome gets a little bit out of whack, the diversity goes up. So in this chart, we're looking at individual patients and the diversity of their oral microbes. So this is kind of what you see in a normal population. This is what you see in ulcerative colitis. Like the diversity shoots up, one by one, individual by individual. In Crohn's disease, fewer patients, but more diversity. You can see PSC shoots up, alcoholics, GERDs. So that's what I was talking about. The diversity goes way up in these conditions. What's going on? Is it cause or is it the effect? Is it the consequence of those conditions? We don't know yet. We're exploring that. So to give you some examples, the oral cavity may serve as a reservoir for Klebsiella. We've probably heard of that one. And we now know that oral microbiota contains the highest abundance of this Enterobacteriaceae compared with other mucosal sites. So there's really this interesting ecology in the mouth that helps nurture and grow some of these microbes, but they're pathobionts. They're bad for you. And once they get a chance to get freed up from the mouth and discharged into the intestine, now you're basically harboring and introducing these microbes where you shouldn't be, right? Not a good thing. So the hypothesis is that a subset of oral microbes may colonize and persist in the intestine under certain circumstances that negatively trigger an immune response. Remember, these are microbes, they're pathogens. Your immune system doesn't want them there. So all you're doing is sending microbes to sort of pick a fight with your immune system in the intestine. Sound familiar? All right, let's give you some actual examples. Now maybe talking closer to IBD. So people have looked at the salivary microbiome of Crohn's patients, and they compared them with when they were in the active disease state versus in remission state, and then healthy controls. So just collect some saliva, send it to a lab, look at all the microbes, check it out, see how they compare. They ranked them, and here's how they came up. The active Crohn's patients, you see in dark blue, had their own pattern of microbes. You see the diversity has actually gone down, but when you have a Crohn's patient in a remission state, their pattern matches to the healthy person. All right, so what's going on? There's an enrichment of certain microbes and loss of certain microbes. There's definitely a discernible pattern here between the active and remission of Crohn's. It's happening in the mouth. Same with ulcerative colitis. When you look at the saliva ulcerative colitis patients, they get grouped into this blue circle or the red circle. Red is all the healthy, UC is all the in the blue, and the composition of the microbes show up in this little bundled sequence that you can actually almost identify or predict. So there's a lot going on in the mouth that perhaps can be used as a biomarker of active disease state or remission or something. In pediatrics, these are children's, I don't know if you know about this, but Children's Healthcare of Atlanta, inpatient wards and outpatient pediatric clinics were enrolled in the study. 30 had Crohn's disease, 17 had ulcerative colitis, 18 were healthy, ranging from 5 to 19 years old. And they discovered that there were higher concentrations of Bacteroides and lower concentrations of Proteobacteria in general. And then when you rank them in different parts of the mouth, they actually sampled from the back of the mouth, the front of the mouth, the saliva, the tongue, and the stool. You can follow the pattern in these patients. Really interesting. I won't go into the details, but there's definitely a discernible pattern of UC patients, a different pattern of Crohn's patients, and a different pattern of the healthy kids. All right, so this is just a quick summary of what they discovered. And in IBD patients, we've detected, again, these microbes that have been associated with inflammatory states, right? They're kind of microbes that pick a fight with your immune system. But guess what? They sort of were originated in the mouth. There we go. All right, so oral pathology is common as an extraintestinal manifestation of Crohn's. So when you have Crohn's, you sometimes get oral manifestations. Some of these are medical terms, but you've probably seen this one, right? Canker sores. I don't know if you guys ever get canker sores when your disease is starting to go into an active state or a flare. Shows up in like this little ulcer in the mouth. I used to get them, right? This sort of like little warning sign in the mouth that, uh-oh, am I going into a flare or not? I'm thinking that's an oral microbial shift, and this is the result of it, okay, ahead of a flare. And maybe that microbial shift can be prevented. Maybe you can stabilize it and maintain this sort of like happy state of the affairs, and when it slides off track, your immune system starts reacting locally and then systemically, and maybe sends you off into a flare. If your immune system's, involved in that pathogenic response. So here are the things. Oral bacteria can reach the gut through swallowing, I mentioned that, of saliva loaded with tons of oral microbes, and then these can induce the gut inflammation. It can also enter the bloodstream, all right, through these ulcerated cavities, these sort of openings in your intestines, and reach the bloodstream through kind of a backdoor entry into your bloodstream. And then through the bloodstream, they can spread systemically and interact with all sorts of places in your immune system. So there's sort of this gut passage that interacts with the immune system inside the intestine, and then there's oral ingestion of the microbe through a blood vessel right there in the mouth, and now you've got systemic exposure to the microbe. And these two strains are there. Now, there's a lot of studies actually done in Crohn's and ulcerative colitis and oral microbiome. I'm just going to list a few of them here. This actually goes on for 3 pages in this review paper. I'm happy to give you all the references at the end, but I'm pretty surprised. There's been actually quite a few studies looking at IBD, UC, Crohn's, and oral microbiome analysis, and I think this is going to be a big topic pretty soon. We're going to start learning a lot. So there's parallels. When the oral cavity is in trouble, you have like periodontitis and dental disease. Again, that barrier function starts disappearing in the tooth lining. The same thing happens in the intestine, right? We heard about that from Dr. Fasano. And then once that happens, in the mouth, you get a whole bunch of sequences, pathways, where one thing leads to another, and you end up with production of TNF-alpha at the bottom, a signaling molecule that your immune system has caught something and needs help. Like it's activation of the immune system. So up top in that diagram, you can see dislocation or dysbiosis of the oral microbiome, entry through barrier gaps in the mouth, and then eventually how it gets picked up by the immune system, and then a call to action through TNF-alpha, among other signaling molecules. These are all biomarkers of inflammatory state, right? Of course, we know about TNF blockers. The same thing happens in the intestine. You got microbes penetrating through a gap in the intestinal lining, being picked up by the immune system, generation of reactive oxygen species, here's nitric oxide, and then production of TNF. That's classic Crohn's or UC. So what happens in the mouth is basically what's happening in the intestine. The mechanism's kind of the same thing as well. Now, a lot of the biologics we know and familiar operate down here at the bottom, right? It's kind of late to try and mop up when there's a ton of TNF-alpha released. You got to be working up here to stop the dam from flowing, right? It's kind of like a broken dam. Do you go remove the water after a dam is broken, or do you just stop the cracks in the dam. So that's the whole story about maintaining good health and oral health. We'll talk about that. So just to summarize this, at the very first stage, there's dental or oral cavity disease, causes oral dysbiosis. This is the oral microbes that are kind of going out of whack. And then you get increased diversity in the oral cavity. This then leads to distribution, or what we call translocation of those microbes, either through a back door, right from your blood vessels in the mouth, entering the systemic pathway, or landing in your gut and causing trouble down there. And then from there, we know what happens. We get TNF production, colitis, inflammation, and so on. So that's the story, and this is kind of how it starts coming together. So, I mean, this is just the geometry of the gut, but the small intestine, you guys know this, not much of a place for microbes to live in. The small intestine is not really infected with microbes. It's really the colon. And then this is sort of like a crosscut of the colon. They kind of hang out in the mucosal layer, and this is where your food passes through. So this is just a kind of a geometric view of it. A couple more drawings of how it all works. I won't spend too much time on this. All right, so now I hope I've made a story about how the oral microbe is susceptible to sort of your behavior, your mouthwash use, et cetera, et cetera. I've explained to you how it sort of sneaks in through a backdoor blood vessel or through your gut, maybe directly causes inflammatory state in the intestine, and then you sort of trigger the whole sequence of IBD or aggravate it. So the question comes up, what are we doing to our oral microbiome? Like, what are all the things we do in daily life that impact it, right? Because it's mostly an environmental or behavioral driver that influences the oral microbiome. So we talked about birth modality, right? C-section versus natural birth. Doesn't seem to make much difference. Breastfeeding doesn't seem to make much difference. So I kind of shaded these in light gray. Diet definitely makes a difference, right? I mentioned, you know, the food that comes in your mouth definitely helps feed the microbes in the oral cavity, and that helps expand the diversity or support a good ecology. Antibiotics does the opposite. Like in the oral cavity, it's probably going to kill, including mouthwash. Smoking probably kills all the microbes in the mouth to some degree. All that toxin, nicotine, oxide, whatever, isn't good for the microbes. They're delicate. They're not going to survive. Medications, disease. These are all things that influence and are well-known drivers. And then contacts, who we touch and contact, who's in our life, who we live with, who we cohabitate. Our dental and oral manipulations. So what are we doing to our mouth from a dental health perspective? So let's talk about orthodontics, braces. So orthodontic treatment with braces has become increasingly common in the US, as you guys know, over the past several decades. In the mid-20th century, orthodontic treatment was just pretty relatively limited and not really accessible to the general public. The American Association of Orthodontists estimates about 4 million Americans at any point have worn braces. This is in 2018. And then in the mid-20th century, this treatment became much more popular, right? So who gets braces? Teenagers, typically, right? 10, 11, 12, 13. Who gets IBD diagnosis? 12, 13, 14, 15, 16. I don't know, right? Well, what's going on? So we know through studies there's a higher microbial diversity among orthodontic patients compared with healthy individuals or people who don't wear braces, right? In fact, this is one strain in orthodontic patients versus people who don't have braces. Shoots way up. So the rough surfaces on the wires and the sort of the brackets provide a nice surface area for the microbes to hang out and then stick around. Like before it was a nice smooth tooth, now it's all these like rough edges, and this results in this diversity increase that can't be really removed with brushing. Okay? Or improper brushing makes it even worse. So I wonder if there is a connection between, this introduction of braces, orthodontic appliances, how it happened in the late 20th century, second half of the 20th century. Same with IBD. I don't know. That needs to be explored. Here are some actual examples of strains that, again, have been found in the oral microbes of patients who are under treatment, dental braces and appliances. Now, fixed appliances, what I just described goes the same for fixed appliances, conventional brackets with these elastomers, molar bands, clear aligners. I mean, all the stuff that you're putting in your mouth is changing the surface composition, the cavities, the sort of like pockets. Do you brush as well? Do you not brush as well? Who's coming? Who's going? I mean, it completely changes the environmental sort of composition of the mouth, and it results in a shift in the oral ecology. So this goes well with mouth guards. Like some people sleep with mouth guards, some people play sports with mouth guards. This is more temporary, but you are putting something in your mouth that's maybe not the most sterile thing in the world, right? All night, it's sitting there. What's that doing? Like that saliva or whatever it is, all night is exposing your mouth to a different environment. Tongue scrapers, like what are they doing? Like people are like using these, and I don't know why. What are they doing? Retainers, mouthwash I already talked about. And then what's this latest thing with teeth whiteners? Like what are all these things people are doing to their teeth to make them look good and white? Gosh, like microbes have no chance. Right? All of these are fairly new, kind of modern inventions. We never did these in 1923 or 1941, right? A lot of this stuff is pretty new, modern sort of health, dental health, but somebody really needs to study the impact of these on not just the ecology of the mouth, but the impact it has on systemic health. So I mentioned all of these things. The list gets longer. So I just talked about the appliances, but we also do other things to our mouth, like removing wisdom teeth in our kind of teens and 20s, right? What's that doing? Tonsillectomy. That's kind of a 20th century thing. There is a tonsil microbiome, by the way. It's actually called the tonsil microbiome. Like that's kind of unique to the tonsil. So you take it out, what does that do to the overall picture? We don't know. Even things like if you're a mouth breather or a nose breather, because when you're a mouth breather, you're bringing in a lot of air, a lot of oxygen, and the microbes better be okay with the oxygen. Not every microbe is okay with oxygen. It's actually a poison to a lot of microbes. So sometimes there's shifts in that dynamic of just the air exposure. And something simple like chewing gum, okay? You put it in your mouth, it's kind of in contact with your teeth, with your tongue, with every part of your mouth for hours a day, maybe. So what is chewing gum? Okay, so I looked it up. Chewing gum is the water-soluble part is the gum, and then you have these sweeteners that make it taste all yummy, and then there's other things that kind of make it all come together. But the sweeteners are sucrose, dextrose, glucose, and then there are these sugar-free gums that pretty much everybody wants. And all these little polyols, xylitol, sorbitol, that's how chewing gum is made, sugar-free chewing gum. And all these polyols are FODMAPs. They're fermentable sugars. Can't have them if you have IBS or reducing your polyols or FODMAPs. So, I mean, is it a good thing to be chewing sugar-free gum for hours a day? Like, what's it doing to the microbes in your mouth? The good ones. So how would you even study that? Like, how do you get chewing gum from people to see turns out there's a really good way to do it. Okay, this is in Seattle. There's actually a tourist attraction. People who locally live here know what I'm talking about. But it's called chewing gum waste. And researchers actually went and collected chewing gum from all over the world and studied the microbes in the gum. Now, this is just Europe and Asia, But you can see the chewing gum composition or the profile is different in different places. They're not making any assumptions or interpretations other than it's diverse and varied. So the gum picks up the microbes. So is that a good thing or a bad thing? Right? We don't know. So getting to the end, but what else can you do that shifts the oral ecology? Well, if you had UC or wanted to change the ecology of the colon, what's the fastest way to do it? Fecal microbial transplants, right? So what's the oral microbiome version of FMT? French kissing. That's right. Involves exchange of saliva, and it can transfer bacteria from one person to another. So wouldn't it be great if you could actually study that? So somebody studied it. This paper came out. What is the oral microbiome version? So the study looked at shaping of the oral microbiome through intimate kissing. How do they study it? Well, they found couples, and they gave one couple a probiotic drink, and then they kissed, and then they picked it up in the second couple. And you can measure the transfer rate, okay? And you profile the saliva, and you can see the transfer rate. And it turns out that every 10 seconds of kissing transfers 80 million microbes from one to the other. Okay? So look, a lot of things influence the oral microbes. I went through a whole sequence from diet, mouthwash, dental hygiene, dental appliances, braces, kissing, chewing gum. It's like an open petri dish, right? Anything can land in there and grow, and then once it goes in the wrong direction, it gets distributed into the intestine, and who knows what causes that. We've already seen very interesting translocation of those microbes getting picked up by the immune system directly into the gut or through the blood vessel. And then I mentioned all sorts of other behavioral aspects that influence this. And a lot of these are late 20th century kind of modern inventions of dental care or dental cosmetics or whatever you want to call it, behavior, etc. So that's kind of the picture. This is what I'm hoping to leave you guys with. But there is a more serious aspect to this because when pharmaceutical companies do drug studies and they come up with the next best thing for, let's say, ulcerative colitis, they enroll the patients, they give everybody the treatment or the placebo, and they hope it makes a difference, right? But they don't look at the background diet of these individuals. Nobody studies that. They don't look at the oral microbiome of these individuals. They don't study that. So you probably have all sorts of people in the study with all sorts of backgrounds in their gut microbiome, oral microbiome, kissing behavior, preferred gum brands, right? All that variability gets buried into the study and into the study noise. And it causes trouble. And it's what we call the therapeutic ceiling. So every IBD medication that's out there has an upper ceiling on how effective it is. Doesn't work for everybody, we know that. In fact, doesn't really work for more than 35% of the population. So this chart shows you the efficacy of people on medications in these trials. These are all for ulcerative colitis. Some of these are drugs you know. And the efficacy rate of the people who got treated in the clinical trial. Pretty dismal rates. 15% benefited. 19% benefited. At best, it's in the 30s. This is the state of affairs in the pharmaceutical space. The efficacy rate is really low. Now, how did the placebo groups do in this study? That's these numbers. So in some studies, 4% placebo benefited, 11. So it's not even that much better than the placebo group. Okay, that's the therapeutic ceiling. And possibly because you're attacking the disease at the wrong part of the pathway. You're at the bottom of this TNF pathway where all the damage has already happened, and now you're just mopping up the TNF. Good luck. And part of it is because all these patients have diverse backgrounds, like diets are different, behavior is different, etc. So that's where the sort of rubber meets the road, is we don't really have good answers to this. And it's holding back the field. And that's why we're all here in this room. We're looking at alternatives and complementary approaches to use diet as a big lever against the disease. Okay, so until we better understand the underlying causes of IBD and the lifestyle factors that impact these underlying causes, we will never really make progress beyond this pitiful efficacy rate, this threshold that we have in IBD. So just to wrap up, I'm going to leave on a more positive note. What are the things you can actually do tonight, tomorrow, next week as a result of all this? All right, so pay more attention to the oral microbiome if you want to understand the gut microbiome. That's kind of my takeaway. Is like you can never really understand the gut microbiome until you understand the oral, because they're connected, and in fact, it's feeding the oral. The oral is feeding the gut. Dysbiosis in the oral microbiome has localized as well as systemic impact on the body physiology. So there's local, like I described, and then systemic. The systemic impact of oral dysbiosis is mediated by this microbial translocation, this swallowing action or backdoor entry through the blood vessel. Residents of the oral microbiome have been found in the gut and stool of IBD patients. What's it doing there? How did it get there? Is it causing trouble? Greater oral microbiome diversity is not a sign of good health. So this is in contrast to the gut, like I mentioned earlier. You don't want to have broad diversity, and that's what the braces and appliances do, is they expand the diversity. Many lifestyle factors influence the composition of the oral microbiome. Some of these lifestyle and behaviorals do not support a healthy microbiome. I went through a whole list of those. And I think we should pay renewed attention to oral hygiene, especially when undergoing dental treatments or procedures. Reducing and eliminating sugars and sweeteners and increasing vegetables and probiotic support the stabilization of the oral microbiome. And then clinical research should factor oral health microbiome as a driver or underlying status of individuals they enroll. I mentioned that. So it's a blind spot right now. Nobody's looking at it. So what are you going to do as individuals to support a healthy microbiome in your own personal lives? I'm going to give you some ideas. So your toothpaste, there are fluoride-containing toothpastes, and you should get the best toothpaste you can get, because fluoride is definitely important in dental health and enamel production, and fluoride is in the water of utilities, water supply, right? It's sort of fortified, but a lot of people don't drink tap water. Like, we've kind of gotten scared of drinking tap water and buy filtered water or put a filter in our houses or buy bottled water. None of that contains fluoride. So there's sort of like maybe a background deficiency in fluoride in general, and you can't just buy fluoride supplements. You have to get that from a dentist, the prescription. So I'm encouraging everybody to make sure they get sort of fluoride-containing toothpaste. Doing dental floss is important, but technique is a lot more important. So there's a bad way to do it, a useless way of doing dental floss, and a useful way of doing dental floss. Learn the right technique. It's important. And doing this slide presentation made me want to go get one of these things. Okay, water pick. So doing everything and then some, and I don't know if it's going to make a difference, but it seems like it's a good idea. Of course, increasing fruits and vegetables, leafy, green vegetables is hugely important, especially root vegetables like beetroot. It's very high in nitrates. And these are all SCD compatible. So guess what? there is a little thing you can buy, a home kit, that you get these little paper strips, just like kind of like your home COVID test. You put your saliva on it, and it measures the amount of nitric oxide production capacity in your oral mouth, in your cavity. Just a little bit of saliva, and it changes color, and it tells you how much nitrate to nitrite to nitric oxide capacity you have. It's a measure of how much nitrates you have in your diet and how much microbes are there to do the conversion. So it's actually a really good color indicator. I did mine this week. So Monday, I was kind of on the depleted end, right? Maybe I wasn't eating a lot of fruits and vegetables or leafy greens or something. On Tuesday, it shot up. That's because I bought a beetroot powder extract supplement and made myself a beetroot drink. And then 2 hours later, measured my thing, and it shot way up. Now, I cheated. I didn't eat the beetroot or whatever. I went and got the powdered supplement with like stevia, just whatever. But you get the message. It's injection of nitrate through vegetable, or especially beetroot, shoots this number up. You can see the color change. It's faded over the week. It used to be even brighter. And then it didn't do much difference the rest of the way, and it's sort of gone back to its normal color. So this is kind of a cool way of testing yourself. I have some from everybody. So come and get your strip. You're technically supposed to do it in the morning when it's kind of all clean and whatever, but you can get these online. It's just like $15 for like 30 of them or 50 of them. It's pretty cheap. So kind of have fun. Maybe give yourself a little indication of, hey, am I getting enough nitrate? One thing I wanted to do is have that drink, shoot my number straight up, and then the next day use some mouthwash, and then repeat the experiment and kind of basically block that increase. Just didn't do it, but you guys can do it. So have fun with this. It's kind of interesting stuff. All right. Again, just to wrap up, cut out the gum, especially the sugar-free gum. Cut out the antiseptic mouthwash, right? If you're doing braces or any kind of dental, be super careful and super meticulous about how you clean and maintain cleanliness. And then, I don't know, like teeth whitening stuff seems pretty harmful, not knowing much more. Like, I don't think that's where you want to go. All right, so just to wrap up, there are now companies that offer kits for just like stool testing, microbiome testing, like home kits. Not sure how good they are, but the sampling is perfect. You just grab it, right? It's totally accessible. Stool microbiome is supposed to be a reflection of gut microbiome, but it has to sort of go through the rectum and end up in the stool. It's not a direct sampling technique. It sort of gets all messed up. So I've never trusted or been able to really interpret stool microbiome tests because it's sort of like not direct sampling. The oral microbiome, you grab it right there. There's your saliva. So I tend to think this might be an interesting thing to explore. And there are a couple of like direct-to-consumer companies that offer this. It's pretty new. And then these are the references that I highlighted. And I have copies of the research studies if you want to take and grab them from me, research, read. It's really fun stuff. But that's as far as I want to go. Thank you very much for your attention. All right. Okay. Thank you, everybody. So thanks for the questions. I'll ask myself these questions, I think, right? Okay, so is there a safe mouthwash to use? My dentist told me to use Listerine twice a day to control plaque. So what I found is the mouthwash industry used to basically approach it like kill everything you can find in the mouth. Like 99% is not as good as 99.9%, effective. So they kind of dialed it up and went overboard. And it's a lot of this alcohol-based mouthwashes. They're really I don't think they taste too good. But there are non-alcohol-based mouthwashes, which I think is the next best thing. So whatever you're getting, look for the non-alcohol-based. Ask your dentist if that's going to take care of the plaque. But I think that's a good kind of pivot you may want to make, whoever asked that question. Is there a difference in the usefulness of nitrates from so-called uncured meats that use celery powder as their nitrate source? Okay, so we're talking about meat stabilizers, meat processing, right? We know about this in SCD, right? We want to stay away from processed meats. Some of the deli meats, they have powders or nitrates added to them. I mentioned that earlier. So tell me about this. So they use celery powder as the source of their nitrate source. All right, so they're basically, it's a nitrate infused, it's a celery infused meat. Is that what you could call it? Right? Celery, I don't know who asked that question. Good question, Michael. So celery powder, to me, is not that different than celery. I guess it's kind of dried up and disintegrated. And then they add it to provide what the function of a nitrate might be. So I guess that's not too bad. Ideally, I'd rather go with the source meat itself, or like cook a chicken breast and slice it into whatever deli slices. But it's definitely a lot better than nitrate treated meats you get in the deli, in the packaged, whatever, right? Oscar Mayer packaging. Like, you don't want that. So I think, technically celery is fine, and if it has high nitrate and they can extract the nitrate and put it on the meat, maybe that's not so bad, right? And in fact, your body can probably use it. All right, do we need to use a non-SCD legal toothpaste? A non-SCD legal toothpaste. So look, what's an SCD illegal toothpaste? You're not swallowing the stuff. Who is that, right? So, I mean, you'll swallow a little bit, but it's not, what are you gonna do? Get cavities or like not take care of your teeth? So I think you just, whatever toothpaste you want, the important thing is just make sure it has fluoride and make sure you don't swallow it. Yeah. Yeah. Okay, so SLS, so Tracy's telling me, so the sodium lauryl sulfate acts as a detergent. It breaks down cell membranes. It kind of maybe opens up a ulcer in your mouth or something. Maybe that's what's going on. So that's an additive to toothpaste. I don't think the Tums toothpaste has that. But yeah, look around, look for good quality toothpaste for sure, right? Fewer stuff, better. But the key thing from my perspective is the fluoride. But I don't think SCD, anyway, that you're taking care of your teeth, and kids will swallow toothpaste, so make sure it doesn't have a lot of fluoride. Be careful, because it tastes good. Like, put sweeteners in it. It's good, it's yummy for them. All right, do we need to, okay, I just asked that question. All right, do you recommend oil pulling, like with coconut oil? So yeah, so the question is, do you recommend oil pulling like with coconut oil? So I did find this in my research. I didn't really understand it, so I didn't include it. So apparently there's this homeopathic treatment where you put, I don't know, a tablespoon of coconut oil in your mouth and you swish it around for 20 minutes. I think that's the routine, and then you spit it out. So what it is chemically is you're removing the fat-soluble waste into the oil. The oil is basically sucking up all the fat-soluble debris or microbes. I don't know what it's doing. And it's going into the fat, oily compartment of the coconut oil, and then you're spitting it out. So it's sort of like, kind of like an oil car wash for your mouth, I guess. So I can't see it being harmful, but, it may knock out some of your microbes in a bad way. I don't know. So, but it's something I came across, and it seems like a thing, but not sure. I'm not sure what to think about it, but I don't think it's the worst thing you can do. Like, you know, chewing gum's probably a lot worse. All right. Do you have data about response? Let's see. Do you have data about response rates to SCD in Crohn's and UC? Oh, okay. So this is a little bit unrelated. Do you have data on response rates to SCD in general? Okay. Yeah, there's a lot of studies who've looked at SCD in pediatrics, in adults, case studies. I have all the publications. I don't know who asked this, but I'm happy to give them to you. Response rates, in comparison to the UC data studies. Yeah, this data's more sparse. So at best, there's like 40 or 50 people in kind of a case series of studies. So statistically, it's not really going to add up. The DINE-CD study that we mentioned yesterday, they looked at a little bit more of that, and it was more controlled intervention. But the problem is, and the response was good, actually, like as good or better than what I showed you here, for sure, for the medications. The problem is it wasn't customized for everybody. Everybody got the same SCD meals from start to finish. And we know SCD needs to be customized. Everybody has different preferences, different tolerances, a start point, a midpoint. So we can talk about the DINE-CD study. I have some problems with it. But even in that setting, they showed significant impact, reduction in inflammation, reduced fecal calprotectin, clinical improvements. I think it was a 6-week stretch, and then they did another 6-week follow-up where they could eat their own meals any way they wanted. But yeah, so we don't have long-term studies. We have anecdotal, everybody in this room, stories we've shared in the past. Technically, they're not considered evidence-based or certainly not randomized controlled trials. You can't do a randomized controlled trial with diet. Definitely can't do it with SCD. Don't hold your breath. It's not going to happen. Doctors will say, where's the evidence? Don't get into a discussion about it because there's other types of evidence out there. RCTs are not the gold standard at all in diet and nutrition intervention. It's a misguided type of thinking, and I don't want to get in. I'm happy to get into that discussion with any doctor because their standard of thinking is RCT, $300 million study. It's not going to happen even if you could do it. All right, a little bit of, okay. So do different strains of the bacteria in the oral biome have preferences in localization in relationship to the tooth, to the taste perception? Interesting. Okay, e.g. the sides off the tongue versus the tips. Yeah, so I showed that 3D model where the microbes kind of localize different parts, they're kind of patchy. Yes, there is different, every niche in your mouth collects a little bit of a different, has a little bit of a different temperature profile, different bit of saliva collects there, the surface is different. So each of those is its own little microenvironment. And because it's a little microenvironment, different microbes will like it, different microbes won't like it. So they will go land and occupy places they like. So it's very patchy, very localized. And the question is, do the sides and front and back of the mouth, tongue, colonize bacteria differently? And then does that impact taste? That's a really interesting question. I don't know. It may dull the taste. It may improve the taste. It may be, who knows? That's a really interesting area to explore. I like that. Okay, let's see. Does the antibiotic use have a long-term effect on, or just while taking the antibiotics? Look, so either, in terms of gut microbiome, when you take oral antibiotic, it zaps pretty much a lot of microbes. Some of them are broad spectrum. They're designed to kill pretty much everything out there. Massive disruption in the gut microbiome. What it's doing in the mouth, I'm not so sure. It doesn't really have a lot of time to hang around in the mouth as an antibiotic, but it definitely does disrupt the gut microbiome. It tries to bounce back once you're off the antibiotics, but it never recovers. You're done. You'll never be the same. Okay? And antibiotics are used not just once, but you'll use them 2, 3, 4, 5. I have a patient, she's been on antibiotics for 18 years. On and off, every year. Okay? So yeah, you can do something to sort of reduce the damage. Fermented foods, probiotics, a lot of prebiotics. Diversifying the prebiotics is probably the most important. But there's ways to sort of bounce back, but I've never seen recovery back to normal. So use it when it's kind of a life and death situation, not just because your doctor's out of ideas and just wants to give you antibiotics. Did you find any info on the sinus microbiome and influence on oral microbiome? Okay, interesting. Sinus microbiome, so everything's connected, obviously. I do see patients who get sinus infections every year. They just sort of like have an unhappy sinus. Same story. Tissue, mucus, barrier, microbes, inflammation, immune system. So I didn't see anything specifically. I wasn't really looking for the sinus microbiome in my research, but I'm sure there's a story there. And viral infections in the sinus, that's what happens to kids, right? So I'm sure there's an overlap and interplay between those two. Yeah, good question. All right. Do you recommend brushing teeth in the morning as soon as you wake up, or rinsing with tap water sufficient? So these are all really good questions. I don't think anybody's really studied this. So I think you have to use some of your judgment, your best judgment, on frequency of toothpaste, brushing, the technique, how you rinse, how many times, before, after a meal, all this stuff. It's hard to study that and then make broad interpretations. So I think everybody should just use your own personal judgment. It's not that complicated. You can kind of be smart about it and take care of business. And throughout the day, think of all these things that you do to maybe hurt your microbiome in the mouth or help it. If you're in a relationship, it may be not that so much the foods you eat, but the food of your girlfriend eats. That's what matters as well. There's a lot of interesting kind of overlapping lifestyle things that come into play. So use your judgment on all this stuff. But this is kind of new science, and we don't have all the answers. But from a practical perspective, you can be smart about it and think of all the things that make a difference. You don't want to worry about every little thing throughout the day. So start at the top and look at the key things that make them, like the 80-20 rule. Do the fewest things that make 80% of the difference. Like, that's a good start, right? Maybe stop using, alcohol-based mouthwash. Like, that's 50% of the way. Don't want antibiotics, blah, blah, blah. So that's the way to go. Don't worry about the minor things yet, because there's probably easier things to fix first. Anyway, that's most of the questions. I hope I got through most of them, but come up to me if I didn't get to your question. And yeah, this is a fascinating area of subject, and I'm going to keep myself tuned in and kind of on the edge of the science and see what we get out of this. I think there's some interesting products that might come out of this story. Maybe probiotic toothpaste, okay? Maybe probiotic gum with beetroots buried in there. I mean, somebody should make that, right? Heck, let's do one. All right, that's all. Thanks, everybody.